Fine. So continuing with this question, a 40-year-old gravida 5 para 1 with 3 abortions A3 at 7 weeks gestation presents with a spontaneous abortion. Her medical history is remarkable for hypothyroidism with a TSH of 1.5 microinternationals per ml on levothyroxine. Type 2 diabetes mellitus with a hemoglobin A1C of 10% on metformin and MTHFR heterozygous mutation. She underwent testing with another physician following her prior miscarriages with normal maternal karyotype and negative antiphospholipid antibody syndrome testing. The products of conception are sent for karyotype, which is normal. Her 44-year-old husband is the father of all her pregnancies. She requests the use of prophylactic anticoagulation in future pregnancies to improve her pregnancy outcomes. Which of the following recommendations is most appropriate? A. Initiation of insulin therapy. B. Increased dose of levothyroxine. C. Consider sperm donor given likely paternal factor. Or D. Begin heparin prophylaxis with missed menses next pregnancy. Did you all follow the question or you want me to read that again? It's a bit complicated. You'll need to read it, at least twice, thrice to kind of note down the important points that what they mentioned here, and then you'll be able to get into the correct option by excluding a few. So shall I read the question once again? Students, I want you to be interactive so that it doesn't become a monotonous one, and I will be assured that you people are there with me and there are no network problems. Okay, please be connected to me. Please respond to whatever I've been asking you people. Hello. I hope you are all there with me. There is no loss of connection. Are you all able to listen or hear to me?
Yes, ma'am.
Okay. So, yeah, coming back to this question, I'll read it again, right? A 40-year-old gravida 5 para 1 abortion 3. She has 3 abortions and she's presenting with a 7 weeks pregnancy with a spontaneous abortion in this pregnancy as well. Now, her medical history is remarkable in the sense she is a known hypothyroidism. Note that her THS is 1.5. 1.5 falls in the normal range. Okay, so TSH of 1.5 is a normal range and she's already on levothyroxine for this time. Another thing, what problem she has is a type 2 diabetes mellitus. And an HbA1c is 10%. What does this indicate? An HbA1c of 10%. What does this indicate, even if she is on metformin? Why is HbA1c done in diabetes mellitus? What is the clinical inference of HbA1c?
It gives an average value of 3 months.
Yeah, average value in the sense average glycemic control. It's not just the value. It gives
Yes.
how well the glycemic control has been there with this patient on an average past 3 months, right? So it gives how good the glycemic control is. So what is the normal HbA1c levels, which shows a good control or a good glycemic control for the for any patient? What is the normal
Less
range? Yes, anybody?
Less than 6.
Less than 6, yeah. It's like 5.5 to 6.5 is what the ideally the ideal where it shows a very good glycemic control. 6.5 to 7.5 and again 8.5 to 9.5 or more than 9.5 is showing that, it is a very trending towards an uncontrolled kind of a diabetes mellitus or an uncontrolled glycemia. So 10% of HbA1c in a patient with diabetes mellitus is definitely abnormal, is it not? Here it's showing 10%, so it shows that the patient is having a highly uncontrolled diabetes mellitus. Now, is there any relationship to the HbA1c and obstetric significance? Is there any obstetric significance with the value of the HbA1c or the control of the sugars in the diabetic patient? Anybody has any idea regarding this? We all know that diabetes mellitus is a risk factor for congenital abnormalities or no?
Yes, ma'am.
Yes, is it not? See, always remember in a general population, if the risk of any congenital abnormalities in a fetus is about 4 to 5%, whereas in diabetes mellitus is almost increases by 2 or 3 times. Okay, and it is directly proportional to the levels of the HbA1c. In the sense, if the HbA1c level is more, that indicates that the diabetes is uncontrolled or the glycemic control is very poor. So in case the HbA1c is more, then it is directly proportional to the incidence of abnormality or congenital abnormality in that particular fetus. Did you get this? See, if the diabetes is well controlled in a patient and the HbA1c is ranging between 5.5 to 6.5, it will almost be like a normal population, and the incidence of the congenital abnormalities in such patients will be almost equal to the normal population. That is about 4 to 5%. But if the patient's diabetes is uncontrolled and the HbA1c goes beyond, like, 7, 8, or 9%, then the incidence of the congenital abnormalities go on increasing in such patients. Got it? So this is what an important point you have to remember. First of all, diabetes mellitus will increase the risk of the congenital malformations in the fetus. Over that, any uncontrolled diabetes mellitus will again further increase the risk of congenital malformations. So more the diabetes mellitus is uncontrolled, more the HbA1c, more the incidence of congenital malformations in the fetus. So everybody is clear with this point? Yes.
Yes, ma'am.
Okay. So once we are clear with this concept that there is the patient is having a high risk for I'll just see if anybody is waiting to get admitted. Right. So once we've understood that the patient is high risk for her abortions, she is high risk for with the hypothyroidism, but it is well controlled with levothyroxine. Another important high risk factor is diabetes mellitus, which is not controlled. So just keep it in mind that this could be one important factor to be remembered. Now, another thing what I've mentioned is MTHFR heterozygous mutation. Anybody has any idea about what do you mean by MTHFR heterozygous mutation? What is MTHFR stands for? Anybody? MTHFR stands for which or what molecule? Anyone? Okay, if not, I'll just proceed. MTHFR stands for methyl tetrahydrofolate reductase. Okay, this is an enzyme which helps in conversion of methionine to homocysteine. Okay, so homocysteine to methionine. So what happens when there's a particular gene, that is the MTHFR gene, there is a mutation of this gene. So there is the conversion of homocysteine to methionine doesn't occur, and the patient will end up with hyperhomocysteinemia, where there will be increased levels of homocysteine levels in the patient's body. So such patients are actually prone for problems related to the blood clotting, in the sense they are having an hypercoagulated state, and they end up in the more episodes of intravascular coagulation like DVT, or even resulting in thromboembolism like TIA, and mild pulmonary embolisms. So they're more prone to intravascular thrombosis rather than any of the other complications which are related to pregnancy. So that's why, though they have mentioned here that the patient is having a MTHFR heterozygous mutation, how significant it would be in front of an uncontrolled diabetes mellitus is what we have to weigh. Okay, so let's keep this in mind. But then going beyond the other points, she underwent testing for another physician following her up with prior miscarriages. And important thing to note here is the normal maternal karyotype, and the antiphospholipid antibody also been evaluated for her, where they have found to be negative. So what are the investigations we do for antiphospholipid antibody syndrome? Is nothing but we test for the presence of autoantibodies. Mainly it is LAC, that is lupus anticoagulant, as well as the APA, that is the antiphospholipid antibodies. So these two important antibodies are tested, and they have found to be negative in this patient. So two important causes for recurrent abortions has been ruled out in this patient. Remember, with these two statements, one is that the karyotype being normal, the congenital genetic causes for the recurrent abortion is ruled out. And another important cause for recurrent abortions, antiphospholipid antibody syndrome, has also been ruled out in the patient. So these are two important statements. Now, the products of conception are sent for karyotype, which is normal. Her 44-year husband is father of all her pregnancies, so there is no kind of new paternity or any other issues of paternity. She requests use of prophylactic anticoagulation in future pregnancies to improve her pregnancy outcomes. Which of the following recommendations is most appropriate? Now, going and keeping in mind all these points, if we go one by one. Now, initiation of insulin therapy, is it one of the important things which we should be doing in this patient? What do you think so?
Yes, ma'am.
Initiation of insulin therapy. Do you think she'll need insulin therapy?
Yes.
Yes, is it not? Because she has such an uncontrolled diabetes and her HbA1c is 10% and she's already taking metformin. That shows that metformin is not giving her a good glycemic control. So the next step would definitely be start her on insulin therapy so that her diabetes is controlled, and subsequently her risk for congenital abnormalities or risk for abortions will come down. Okay, so this is definitely going to be a one important recommendation or a therapy what we would be thinking of for this patient. Second one, increased dose of levothyroxine. Does she need any alterations in the levothyroxine levels in the dosage? As it is,
No,
they
ma'am.
mentioned the TSH of 1.5 is there. So it's already normal, whatever the dose of levothyroxine she's taking. So she doesn't need this at all. Now consider sperm donor given likely pattern factor. Now, remember one important point is that the karyotype has been done for for the patient. It's normal, what they say. And the pattern of the abortions, whatever they mentioned, the recurrent abortions has nothing actually to do with any paternal karyotyping or problems in there. So most of them are all X-linked. So that's why this particular point also will not be of any significance for this patient. Now the last one, that is begin heparin prophylaxis with missed menses next pregnancy. Do you think this intervention would help this patient? When do you start heparin prophylaxis in any patient with recurrent abortion? In which documented problem, or if there is a documented cause for recurrent abortions, what is the indication for heparin prophylaxis for recurrent abortions? Yes, students, we have discussed this in the theory part, is it not? Hmm? See, heparin prophylaxis is given in patients with proven antiphospholipid antibody syndrome, where the antibodies tested have been positive for that particular patient. And once it has been diagnosed in subsequent pregnancies, immediately with a missed period and confirmation of pregnancy, intrauterine pregnancy, and the when you document the presence of the cardia, immediately you start with the heparin prophylaxis for such patients. Usually we use low molecular weight heparin, either in the dose of 40 milligrams or 60 milligrams, depending on the body weight of the patient, daily. So this heparin prophylaxis is started immediately once the pregnancy is diagnosed, up till 34 weeks of pregnancy. After that, we stop it, see that the patient delivers, and subsequently postpartum as well, we again restart with heparin prophylaxis, or after 6 to 8 weeks of pregnancy, we put her on switch her on to warfarin, that is an oral anticoagulant. So this is a standard prophylactic therapy which is given, but in patients proven to have antiphospholipid antibody syndromes. So in this particular patient, you can note that the patient has been tested negative for antiphospholipid antibody syndrome. So does this recommendation help this patient?
No, ma'am.
No, ma'am.
No, is it not? So this option is also ruled out. So then what we remain is with the option A, which is the correct answer for this question. That is, she definitely needs an initiation of insulin therapy, whereas all other three interventions, whatever have been mentioned, is not going to help this particular patient with all these problems mentioned. So that's how you can rule out each of the options and come to a right, correct or the right answer. So is it clear to all of you?
Yes, ma'am.
Yes, ma'am.
Fine. So the next question, consumption of which of the following legal substances in large quantities is most clearly associated with an increased risk of miscarriage? Alcohol, tobacco, caffeine, or phthalates? This is an easy one. I want you to quickly answer this.
Caffeine.
Caffeine in higher doses is very unlikely to cause abortion. No, that's a wrong answer actually.
Alcohol.
Alcohol is the right answer. Yes. So remember, alcohol is the right answer. And in high doses, it will lead to a higher incidence of miscarriage, whereas not tobacco and caffeine or phthalates. Okay. Now, coming to this question, a 20-year-old woman at 4 to 5 weeks gestation by last menstrual period presents with vaginal spotting and cramping. On examination, her cervical os is closed, and pelvic ultrasound image reveals no evidence of intrauterine pregnancy or an adnexal mass. Her progesterone level is 12 nanogram per ml, and beta HCG level is 456 milli-international units per ml. What is the correct diagnosis? Missed abortion, ectopic pregnancy, threatened abortion, or pregnancy of unknown location? Anybody with this answer?
Ma'am, option D.
D. Option D is the right answer, whatever she has told, that is pregnancy of unknown location. Okay, so you all remember that there is an entity called as pregnancy of unknown location. So as she told that this is the right answer for this particular situation, where remember what all they have mentioned is she's just 4 to 5 weeks according to her LMP, and the time when we see the gestational sac or the first evidence of pregnancy on the scan is about 5 weeks at least, so or 4 to 5 weeks in some cases. So by this time we should actually be just able to see or even not see a small gestational sac in the intrauterine or extrauterine period. So remember what they have mentioned here is, though she's having vaginal spotting and cramping, her os is closed, and pelvic USG shows that there is no evidence of intrauterine as well as adnexal mass, right? And another important thing what you remember is the beta HCG level here. So the beta HCG level here is just 456 milli-international per ml. You all should be able to remember the beta HCG levels corresponding to different weeks of pregnancy. So how what is the level of the beta HCG in each weeks of pregnancy is very important to remember in such cases. So we'll go to that table later. I have put it up, but for regarding this question, we have to rule out that all these other three options are wrong. See, missed abortion can't be an option. When you call it as a missed abortion, you should be able to see a proper gestational sac within the uterine cavity. You should be able to see a fetal pole also. So only the absence of the cardia in the fetal pole in a gestational sac, that indicates that it's a missed abortion, right? So it's not an option here because as it is, they're not able to see any gestational sac within the intrauterine cavity. Now, ectopic pregnancy is also not an option because, as they mentioned, there is no adnexal mass here. Okay, and it again can't be threatened abortion because threatened abortion, it has to have a normal documented pregnancy where they have been able to see the gestational sac, the fetal pole, even the cardia should be present in a threatened abortion. So these three options are ruled out, and according to what the findings have been mentioned here, the last one, that is pregnancy of unknown location, points to be the correct answer. Okay. So as I told, it's important for you all to remember the HCG values in different weeks of pregnancy. Remember, it starts raising by about 3 weeks, 4 weeks. Then it's like 5 weeks, 6 weeks, and this is how it ranges. Highest is between 9 to 12 weeks, where it peaks. Okay, it peaks and then it starts falling again after 12 to 13 weeks. It starts falling again. So between 9 to 12 weeks or 10 weeks is the peak of the HCG. Another thing what you have to remember is the beta HCG doubles every 24 hours to 48 hours. That means it increases for example, if it's 200 today, after about 2 days, if you repeat the HCG values, it should have gone to 400 plus. So it doubles after every 24 to 48 hours in a normal pregnancy. So this is a very important point what we use in clinical practice, where we do serial beta HCGs whenever there is a pregnancy in question like this, where the beta HCG is positive, but there is no gestational sac either seen in the intrauterine or the extrauterine cavity. What we do is we follow up with the beta HCG levels. We repeat the beta HCG level after 2 days. So normal pregnancy, if there is a normal pregnancy, then the beta HCG level has to double every 24 to 48 hours. If the beta HCG level is same or it is falling, then it indicates an abnormal pregnancy or even an ectopic pregnancy. So important, it is an important investigation and prognosticating factor as well, the beta HCG values being evaluated in pregnancy. So this is an important point or the chart what you have to remember and correlate. Always we correlate the beta HCG levels with the ultrasound findings. So whenever there is like 5 to 6 weeks pregnancy and the beta HCG levels, what we expect is between 1000 to 56,000. So at this stage of pregnancy, we should be able to see a gestational sac in the ultrasonography. So that's how we correlate the beta HCG values, the weeks of pregnancy, as well as the ultrasound findings, and come to some conclusion regards to whether the pregnancy is normally growing or it's abnormal or it's a ectopic pregnancy or whatever. So that's how it's the clinically the beta HCG values are prognosticated. So just a few more points about HCG. I'll just read out these, and each and every point is important. Just listen to this. Now, the levels of HCG can vary widely between women with normal pregnancies. As I had told in the table, it varies from 5 weeks it's 18, even in few women, and few women it might be high, like 7. So, but then the range is this. What's more important, as I told, is the doubling time of the HCG. That's very important. Typically, serum and urine concentrations of HCG rise exponentially in the first trimester of pregnancy, doubling about every 24 hours during the first 8 weeks. Now, the peak is usually around 10 weeks of gestation, and then levels decrease until about the 16th week of gestation, where they remain fairly constant until term. Patients who have HCG levels that plateau prior to 8 weeks or that fail to double commonly have a non-viable pregnancy, whether intrauterine or extrauterine. Extrauterine or ectopic pregnancies usually have a rate of rise that is low without the typical doubling. However, given the large range of normal HCG levels and inconsistent rates of rise of this hormone, checking serum levels is typically paired with ultrasound evaluation to improve the sensitivity and specificity. Return of HCG to zero following delivery or termination of pregnancy ranges from 7 to 60 days. Trending the fall of the HCG levels can be important in termination of molar pregnancies, and also following the termination of normal or ectopic pregnancies, to be assured that the therapy has been successful. So regarding this last point, what I would like to again stress that it's not only used for diagnosis or confirmation of the pregnancy and following up whether it is a viable or a non-viable pregnancy, but post-abortion or post-ectopic pregnancies where they have been managed medically. So we look for the beta HCG levels. The falling trends of beta HCG levels are very reassuring that the patient has responded to your medical therapy in ectopic pregnancies. Another important condition where we have to follow up with the beta HCG levels is the molar pregnancy. So you all know the molar pregnancy, the beta HCG levels soar high. They're in lakhs and lakhs. Normally, it's in thousands in the normal pregnancy, whereas in molar pregnancies, the HCG levels cross even up to 3 to 5 lakhs. Okay, so once it is evacuated, the beta HCG levels dramatically fall down. And remember that the beta HCG levels should actually fall by 1 log. That means if post evacuation of the molar pregnancy, if the beta-HCG immediately after the evacuation is 1 lakh, and then when you test it after about a week, it should come down 10 less. That means it has to come down to 10,000. Then subsequently in the next week it has to come down by one more zero. That means it has to come back to 1,000. So this is how is the normal falling trend of the beta HCG after complete evacuation of the molar pregnancies. So that's important to follow up in any case. And another important reason why we follow up the HCG levels in molar pregnancy is to observe if the patient has not gone into choriocarcinoma. So the choriocarcinoma is one important complication or a sequelae after molar pregnancies. And in case the patient has ended up in a choriocarcinoma post molar pregnancy, the beta HCG levels start rising again. Okay, so that's why we monitor the beta HCG levels after the molar pregnancy. One thing is to confirm that there is complete evacuation. Second thing is to follow up even up till 6 months post delivery or post evacuation of the molar pregnancy. We follow the patient so that she has to see that she doesn't end up in a choriocarcinoma. So is it clear to all of you students what is the importance of HCG? Have you all understood? It's mainly the clinical significance.
Yes.
Okay. Fine, we go to the next question. The patient in question 1810 presents for follow-up 48 hours later. Let me read that question 10 again because you might have forgotten. Now, here, what was the question? A 20-year-old woman at 4 to 5 weeks gestation by last menstrual period presents with a vaginal spotting and cramping. On examination, her cervical os is closed, pelvic ultrasound image reveals no evidence of intrauterine or adnexal mass. Her progesterone level is 12, her beta HCG is 456. Okay, so this patient, the next question relates to the same one. The patient in question 1810 presents for follow-up 48 hours later. She denies further bleeding or abdominal pain. Her beta HCG level is 796 milli-internationals per ml. What is the most appropriate course of action in such a situation? A. Repeat pelvic sonogram. B. Administer methotrexate. Repeat beta HCG level in 48 hours or administer supplemental progesterone. So what do you think you should be doing this patient? The same patient, she's coming back to you after 48 hours, her beta HCG levels are 796. Earlier, her beta HCG levels were 456. So what do you think? From 456, it has gone to 796. Is it normal? Is it normally increasing? Yes or no?
Yes.
Yes, is it not? It's almost double from 400 odd to 700, almost 800. So it's almost double, right, in 48 hours. And that's what we want. That's what is the normal trend of beta HCG. So since it's normal and at the value of 700 or 800, if you go by looking at what would be corresponding to an ultrasound finding at that low level, that is around 700, we wouldn't be able to actually may not be able to find any evidence of the pregnancy on ultrasound. For the gestational sac to be seen on a transvaginal sonography, what we expect the levels of the beta HCG is around 1,000 to 1,500 ml. So with this 800, around 800 beta HCG, this option A, repeating pelvic sonogram, wouldn't definitely be a option because we may not be able to see a gestational sac at this level of HCG. Am I right? Do you agree with me?
Yes, ma'am.
Okay. So then coming to the next option, that is administer methotrexate. Do you want to administer methotrexate for this patient? When is
No, ma'am.
methotrexate administered? No, is it not? Because methotrexate is an antitoxic. We give it as a management of ectopic pregnancy, and that to unruptured ectopic pregnancy where the patient is stable. And in this case, there has not been documentation whether it is still an intrauterine or an extrauterine pregnancy, right? So you cannot administer methotrexate here in this case. Now coming to the third option, that is C, repeat beta HCG levels in 48 hours. Do you want to do that in this patient? Yes? Yes or no?
Yes, ma'am.
No, ma'am.
Yes, is it not? See, as it
Yes,
is
ma'am.
one trend of her beta HCG, sure, there is an increasing trend. There is a doubling in 48 hours. Is it not? So it is indicating that she is going towards a normal growth of pregnancy. So definitely you would want to wait and then repeat another one after 48 hours and see from 796, that is about 800, is she again going into a doubling stage of the beta HCG or no? So definitely you would want to repeat and wait in this pregnancy, because another important thing what they mentioned is that her she denies any further bleeding or abdominal pain. Remember this. So there is no bleeding, there is no abdominal pain, and there is a rising trend of beta HCG. So you definitely want to repeat that again after 48 hours and see that there is a doubling of the beta HCG or no. And accordingly, you take a call once you get the values. So you would definitely want to wait and repeat the beta HCG in this case. Administering supplemental progesterone is again is not a definite option, I would say, because still the confirmation of the pregnancy has not been done, in the sense it has not reached a stage where you can document the gestational sac. But if it were to be a PGI question where multiple right answers would have been the way, then definitely we can tick administration of supplemental progesterone, because prophylactically in patients like this, we do supplement them with progesterones, especially micronized progesterones. Okay, so as far as this particular question, if there's just one option to be ticked, then this would be the C, that is repeating beta HCG levels in 48 hours would be the most appropriate answer for this question. Okay. Next one, the patient in question 1811, that's the same patient. Okay, presents for follow-up with appropriately rising beta HCG levels and is eventually diagnosed with a threatened abortion. When counseling her regarding adverse outcomes related to threatened abortion, you inform her she may be at increased risk of which of the following: preterm birth, placenta previa, placental abruption, or all of the above. So they're just asking what are the risk factors if in a patient with threatened abortion and subsequently continuing with the pregnancy. What could be the risk factors? Is it one of the three or all of the above?
All of the above.
Yeah, all of the above is right answer here. The patient in question with the threatened abortion, they are under the very high risk of going into a preterm labor, even placenta previa, because most of the times placenta previa is the cause of threatened abortion with a slight amount of bleeding. Placental abruption also has been shown to be a risk factor in such patients. So the answer here is all of the above. Okay. Next, a 32-year-old Gravida 3 para 2 at 6 weeks gestation by last menstrual period presents with vaginal spotting. A pelvic sonogram is done with the findings shown below. The gestational sac measures 22 mm by 20 mm by 31 mm. When counseling the patient regarding her management options, which is least appropriate? Expectant management, administer misoprostol, repeat sonogram in 2 weeks, perform DNC. Anybody with this answer? I hope you understood the question first. So remember, it's third gravida, 6 weeks gestation, and the pelvic sonography is showing a sac which is about 22 mm by 20 mm, 31 mm, and you have to note the things properly in the sonogram. The picture here, there is a gestational sac. What is this you're seeing inside here? What is this round thing here? Can you make out, students? Here, can you make that out? Hello? Hello? I'm unable to listen to anybody. Are you all there with me?
Yes, ma'am.
Okay. There was some disturbance in between.
D, ma'am.
Sorry? No, I just want you to tell the structure in the ultrasound in this picture. What are you able to see? This is, of course, the gestational sac. Everybody's clear. What is this here inside? Inside the gestational sac, in the early pregnancy, what is that thing you will be seeing in the sac, in the sonography? What are the structures you'll be seeing in the early pregnancy scans? Anybody? It's the yolk sac. Okay. Can you see this round white structure here?
Yolk sac.
This is the yolk sac. Okay. So at 6 weeks of
Yolk sac.
gestation, what all the things you should be able to see?
Yolk
You
sac.
should be able, yeah, yolk sac, of course. So you should be able to see the gestational sac, the yolk sac, as well as the fetal pole.
Yolk sac, ma'am.
Yes, yes, it is yolk sac. Yes. I hope you are able to hear me. Is there a disconnectivity? Hello?
Yes, ma'am.
Yeah. Yeah, so it's yolk sac, and you should be able to see at 6 weeks, you should be able to see a fetal pole also,
No,
actually,
ma'am.
and then with the fetal heart. But in this particular image, what you're seeing is only a yolk sac and the gestational sac. There is no fetal pole here. Okay, so whenever there is such an abnormality, it indicates to an abnormal pregnancy. That is what we call as a blighted ovum or a an embryonic pregnancy where there is no embryo or there is no fetal pole, right? So though the gestational sac is measuring 22 to 31 see, there is a chart or a table which shows that at what particular week the what is the gestational sac which is measured normally. So there is a chart. So according to that chart, if you go by the sonological books, a gestational sac measuring about 22 or 31 is definitely corresponding to 6 weeks of pregnancy. Okay, so 6 weeks of pregnancy, there is a good normal gestational sac measuring 31 but still you are not able to see a fetal pole. That definitely indicates that this pregnancy is not normal. It's an blighted ovum or an embryonic pregnancy. Now, in such conditions, whenever you have diagnosed an embryonic or a blighted ovum at this stage, what are the things you would do to this patient? And remember, they have twisted the question here, which is least appropriate. That means which you do not want to do for this patient. Okay. Are you clear with the question? Yeah.
Yes, ma'am.
So would you want to do an expectant management for this patient? Would you want to wait for this patient? Would you like to wait? Wait in the sense expected management in the sense you call her after some time, repeat the scan and see if the fetal pole is coming up. You know, do you want to do an expectant management for this patient? Yes or no? You would
Yes,
want to
ma'am.
wait, is it not? You would want to wait. See, straight away with just one in any abnormal pregnancy, whenever you're diagnosing it early pregnancy, and you are not able to find a fetal pole, straight away you do not terminate the pregnancy because you never know, it could be a late conception. So you wait, always you wait, you repeat the scan again after 1 week to 10 days, confirm that the findings are same to the previous scan, and still the fetal pole has not come, and then only once you confirm and you kind of assure the patient that it's not going to grow after the repeat scan, then only you go ahead with the termination. Until then you would want to wait and see that you give an expectant management to this patient, especially when she's clinically stable. Okay, here remember the patient is just having vaginal spotting. If it were to be a patient presenting clinically with acute heavy bleeding, the os open, and she's already in an inevitable abortion state, then of course you cannot do an expectant management. You have to terminate in that case. But in this case, as the patient is just having vaginal spotting and the os is closed, you can still try for an expected management, right? Now, do you want to administer misoprostol for this patient? See, one side you want to do an expectant management, and the other side you immediately do not want to terminate this patient, is it not?
Yes, ma'am.
Yeah. So, do you want to administer misoprostol for this patient?
No.
No. Yes. Anybody? This question is pretty confusing actually. So it'll all depend on how the patient is going to take it. You can do an expected management. You can do direct administration of administering misoprostol because you have confirmed 6 weeks there is no fetal pole, and a gestational sac of 20 ml, no fetal pole is definitely an abnormal thing. So if the patient wants a termination right away, you can go ahead with the administration of misoprostol as well. Okay. And the third option, that is repeating the sonogram in 2 weeks. Do you want to do this?
Yes, ma'am.
Yes, ma'am.
Do you want to do this in this patient? Yes, you would want to do, is it not? So you would want to wait if the patient is kind of anxious, and if she's not sure that not going to work for her, but still she would want to wait. So you wait, repeat the sonogram in 2 weeks again and confirm that it's not going to grow. Then perform DNC. Are you going to perform DNC straight away for this patient? 6 weeks?
No, ma'am.
No, ma'am.
No, is it not? So this patient, just 6 weeks with an abnormal pregnancy, she can still be entitled for even if she wants to terminate straight away, you can go ahead with medical abortion for this patient, rather going for a direct DNC. Is it not? Yes or no?
Yes, ma'am.
Yes.
So directly going or performing a DNC is the least appropriate option for this patient. Is it not? We could go for an expected management. We can administer misoprostol if she doesn't want to continue and she's kind of convinced that it's not going to grow. And maybe we could even repeat sonography if she wants to wait. But performing DNC, even if she doesn't want to wait, is not an option here because she can be given an option of medical abortion because she's just still 6 weeks gestation. So we can try with a medical or a non-invasive option first, and then finally, if it doesn't work or if there's an incomplete abortion, then we can, as a last resort, perform a DNC for such patient. So that's how in clinical practice we do, and we would advise this patient also. So you all agree with the discussion whatever we had, and hope you have understood the clinical scenario, how it comes, and how you have to take the decisions. Okay.
Yes, ma'am.
Fine. So just briefly going through the theory, as I told, there is a proper chart of the gestational sac. At what weeks of pregnancy, how much is the gestational sac? Similarly, there is CRL, there is the heart rate, the mean gestational sac diameter, and the yolk sac diameter. So these are all tabulated. They have been calculated over a period of so many studies, and they have put up in the 5th centile, 95th centile, and 50th centile. So this is the average. This is the lowest what we can see in a normal pregnancy, and this is the highest what we can see in the normal pregnancy, and this is the average. So that's what these percentile stands for. So if you go by the graph, remember this is like, again, as I told, this is the blue one is 5th percentile, this is mean, that is 50th percentile, and the green one standing for 95th percentile. So this chart just explains that how you calculate the gestational sac diameter in relation to the weeks of pregnancy. And you can see that in this particular patient, when the pregnancy is about 6 weeks, right? So what we expect the patient's the gestational sac diameter, at least if you go by the average, if you want to go by the average also, that is the red line. So by 6 weeks, here the patient should be at least 12 mm, or to the safer side, it normally should go up till at least 20 mm, 20 to 24 mm, right? By 7 weeks, it's almost 24 mm. So this is how they chart, and if the gestational sac is measuring 20 mm, 24 mm, corresponding to 6 or 7 weeks of gestation, and if she still doesn't have a fetal pole inside the gestation sac, it shows that the pregnancy is abnormal. And that's how you can counsel the patient that probably this is an embryonic pregnancy and it's not going to grow, and it's not a normal pregnancy, and she might have to terminate it. So did you all understand this concept here?
Yes, ma'am.
Okay, so moving on to the next question. Now, the patient in question 1813 elects for administration of misoprostol, 800 microgram vaginally. When called for follow-up 48 hours later, she reports some light spotting, but no bleeding or passage of tissue. She would like to avoid surgical dilatation and curettage if possible. Which of the following regimens should be recommended? A. Mifepristone 200 milligram oral. Misoprostol 800 microgram vaginally, misoprostol 200 microgram sublingually, or misoprostol 800 microgram vaginally plus mifepristone 600 milligram orally. Yes, anybody with this answer? When is mifepristone given for MTP or an abortion case? Why is it given, first of all? Anybody? Anybody? Yes, students. See, mifepristone is actually an anti-progesterone. Okay, so whenever there is a viable pregnancy and you want to medically terminate, like an MTP, an induced abortion, you want to kind of stop the progression of the pregnancy and you want to halt it, then it is helpful. You know, mifepristone is helpful as an anti-progesterone. It will kind of reduce the progression of the pregnancy. So that's why we give mifepristone first. Now, whereas in this patient in question here, she's already having an abnormal pregnancy. In the sense, it's a blighted ovum. There is no fetal pole. So in this case, do you think the mifepristone is going to help her or not help her? Or is it indicated or no, first of all, in this patient? She is not having a fetal pole at all. Is mifepristone needed for such pregnancies for termination?
No, ma'am.
No, is it not? Because as it is, it's an abnormal pregnancy. There is no fetal pole, and you do not. Mifepristone is not going to help in any way in halting the pregnancy as such. So that's why these two options, where there is a mention of mifepristone to be used for this patient, that is A and D, will be ruled out. Is it not? So this patient doesn't need mifepristone here, not here. Along with misoprostol also, you do not want to give the mifepristone. Clear to all of you? Agree?
Yes, ma'am.
So we're left with two options. Either we repeat the misoprostol 800 vaginally or give 200 sublingually. Which is more preferred? See, as it is with the patient has not expelled with one dose of misoprostol. That's what is been mentioned here. When you want to terminate the pregnancy, she has taken misoprostol 800 microgram vaginally once, but she's not expelled anything. So again, she comes back to you after 48 hours. Which one do you prefer? Do you want to repeat the same dose again, or you want to give just one small dose of misoprostol with sublingual route?
Ma'am,
Which route
sublingual
of
route.
administration? Sublingual route is okay, but then see, remember the most preferred route for misoprostol is vaginal, okay, because it acts much better locally, and the dose for the sublingual, whatever they mentioned, 200 is definitely not going to be adequate for her to help expel the products of conception, which is almost 6 weeks, right? So we need to give a higher dose of misoprostol to her. So the option here, the B option, that is 800 microgram vaginally, again is what we would definitely try with this patient rather than giving just 200 microgram sublingual misoprostol, which is not going to be effective in her for expelling a 6 weeks pregnancy. Okay, so the answer here would be misoprostol 800 microgram vaginally. Again, we repeat the same thing again for this patient. Is it clear to all of you? Hope you have understood and agreed.
Yes, ma'am, it's clear, ma'am.
Yes, ma'am.
Right. So we'll go to the next one. A woman presents with her partner to the emergency department complaining of abdominal pain and fever. She has a temperature of 41 degrees centigrade, a blood pressure of 78 by 42 mmHg, no rebound or guarding, but exquisite cervical motion tenderness and generalized malaise. After asking her partner to leave the room, she discloses that she underwent an illegal abortion at approximately 8 weeks gestation last night. You diagnose her with a septic abortion and begin broad spectrum antibiotic therapy. Which pathogenic organism do you suspect given the severity of her illness? E. coli, Mycoplasma hominis, group A streptococcus, or group B streptococcus? Anybody with this answer? It's more of a theoretical one. Clinically, they have already given you the diagnosis that she is running fever, she's in hypotension, and she's also giving a history of illegal abortion, and definitely she's in a septic abortion, right? So what they've asked here is, according to her history of progression into septic abortion, which is the microorganisms you suspect?
Group A streptococcus.
Yeah, that is the right answer. Why do you opt for that? Group A streptococcus. Can you just brief me? Whereas, which is the most common organism actually isolated from septic abortion cases?
Most common might be E. coli. I'm not sure about, but group A
Mhm.
streptococcus is very notorious. Progression of the septic situation is very high.
Yes, so you're absolutely right. Most common organism actually isolated from most of the septic abortions is E. coli, where it transmits from the normal urinary tract very easily, and then the patient ends up with local infection first, and then she will end up in a over a period of time. It will take time for her to actually worsen to go into worsening situation from a local infection to a pelvic infection and then septicemia. But here, typically, in this patient, they have very clearly mentioned that she has undergone, illegal abortion last night itself. That means it's just one day, or even not even a day. So it's just one night, and within that itself, there is a very significant progression of the sepsis, leading to hypotension and even shock. The patient is already in septic shock, so it definitely indicates a very pathogenic and a very virulent organism, and it's definitely group A streptococcus, which is, as you mentioned, it's notorious, and it spreads very rampantly, and the clinical progression to complications like septicemia and septic shock is very, very faster in such cases, right? So the answer here is C. Everybody's clear with this?
Yes, ma'am.
Yeah, we'll go to the next one. Now, the patient in question 1817, that's the same one, improved with parenteral antibiotics and supportive care. Her blood type is noted to be A negative. You explain the indication for a dose of anti-D immunoglobulin. You inform her that approximately what percentage of women undergoing induced abortion will become alloimmunized without immunoglobulin. A 1%, B 2%, 4 to 5%, or 8 to 10%. Anybody with this answer? First of all, in any abortion case, when in an Rh negative patient, is there a risk of alloimmunization? Yes or no?
Yes, ma'am.
Yes, ma'am.
And anybody has an idea how much is the anti-D given normally? What is the dose of the anti-D which we give normally to any patient as a prophylaxis? After delivery, after a normal delivery, after a term delivery, what is the dose of the NTD given? Yes. What is the dose of the NTD given? How much is the NTD given? You give normally after delivery. After delivery, you check the baby's blood and give. Is it not to the patient? It's 300 micrograms. Okay, 300 micrograms of NTD is the standard dose which is given after delivery. But in the first trimester of pregnancy, the recommended dose is anybody? What is the recommended dose of NTD in the first trimester abortion, Rh negative case as a prophylaxis? Hmm? It's just 50 micrograms. The recommended dose is just 50 micrograms, but sometimes in the market, if we do not get 50 microgram NTD, we end up giving a higher dose, that is 300. What is the standard available in the market? We give it off in the first trimester. But remember, any abortion in a Rh negative patient, always we need to give the prophylactic NTD. Okay, so what the question here is, they have asked how much is the percentage that the patient might get alloimmunized with a first trimester abortion. Anybody with this answer? It's more of a theoretical question. If not, I'll give you the answer. Yes? Okay, fine. The answer here is C. That is 4 to 5%. Okay, so that is the risk of alloimmunization in a patient with abortion and induced abortion. In normal pregnancy, the rate of alloimmunization if the patient is not receiving NTD at the term delivery, it's about 7.5%. Okay, and in some situations like abruptio placentae, where there has been a breach of the placental barrier and a lot of possibility of the fetal cells pushing up into the maternal blood vessels, the alloimmunization risk even increases in case of abruptio placentae. So sometimes there is a recommendation that in the normal pregnancy and a delivery, if you're giving 300 micrograms, in case of an abruptio placentae in a Rh negative patient, you might have to increase the dose of the NTD given to that patient. Okay, so is it clear to all of you?
Yes, ma'am.
Fine. We'll just move to the next question. A 20-year-old Gravida 2 Para 0A2 presents for follow-up after spontaneous miscarriage at 7 weeks gestation. She demands that you do something to prevent miscarriages in future pregnancies. You offer evaluation for pregnancy loss, but provide reassurance that a likelihood of a successful next pregnancy is approximately what percent? 74%, 82%, 86%, or 92%? This is again a theoretical question. So if anybody knows the answer, they're asking what is the chance that she'll have a normal pregnancy in the future, even though she has had 2 miscarriages. Anybody? It's 92%. Answer is D. Okay. So this is of the patient, though she's had 2 miscarriages, the chances that she's having a normal pregnancy in the subsequent one will be 92%. That means the risk of having a recurrent abortion is 8% in this patient. Remember this. Okay. Next one. Which of the following is not a widely accepted cause of recurrent pregnancy loss? Uterine structural abnormalities, parental chromosomal abnormalities, antiphospholipid antibody syndrome, or progesterone deficiency? Yes. This is a very easy one. Are you all there, students? I hope we have not lost the connection.
Yes, ma'am.
Yes, ma'am.
Yeah. So answer this one. It's pretty easy. So which is the least likely cause of recurrent abortions? Uterine structural abnormalities will cause recurrent abortions or no? Yes, is it not? Structural abnormalities in the uterus like septal defects or even congenital abnormalities in the uterine structure will definitely lead to recurrent abortions. So that is one important thing which will cause abortions. We have some student joining here. Okay, so this is definitely the cause for recurrent abortions. Second, that is chromosomal abnormalities in the parents also will lead to recurrent abortions, maybe first trimester abortions. And of course, antiphospholipid antibody syndrome is also a cause for recurrent abortions. So what we're left with is this option, that is progesterone deficiency, which is definitely not been proven to be a cause for recurrent abortion. So this will be the answer for this question. Fine, you all agree?
Yes, ma'am.
Yes,
Right.
ma'am.
Next question. What percentage of recurrent pregnancy loss is due to parental chromosomal abnormalities? This is again a theoretical question. If anybody knows, fine. If not, I'll just give you the answer quickly so that we move to the next questions. Anyone? The answer is
Don't
A,
know, ma'am.
2 to 4%. 2 to 4% of the patients with recurrent abortions will have, the problem of chromosomal abnormalities in the parents, right? So just remember this one, 2 to 4%. Next one, which of the following clinical scenarios is not an indication for antiphospholipid antibody testing? History of 3 embryonic losses, history of fetal loss at 16 weeks gestation, history of unexplained thromboembolism, or history of severe preeclampsia requiring delivery at 38 weeks gestation. So here you should remember what are the diagnostic criteria for antiphospholipid antibody. There are clinical criteria and there are laboratory criteria, is it not, for antiphospholipid antibody syndrome diagnosis. So these are the clinical criteria have been enumerated here. So if you all can remember, then you will be able to answer this question. Anybody with the answer? Yes, students? Fine. We'll just go by one now. First option, that is history of 3 embryonic losses. Will there be a recurrent abnormal pregnancy losses in antiphospholipid antibody syndrome or no?
Yes, ma'am.
Yes, ma'am.
Recurrent.
Yes. So this is one criterion, is it not? Then, of course, there could be first trimester losses or even second trimester losses, that is 16 weeks. So even this is a criteria for antiphospholipid antibody syndrome. This is also a clinical feature. Coming to one, history of unexplained thromboembolism. Thromboembolism is a feature of antiphospholipid antibody syndrome or no?
No, ma'am.
The main pathophysiology of antiphospholipid antibody is actually thromboembolism. Okay, so it's the thromboembolism which is causing all the problems in such patients. So they will be prone for DVT or pulmonary embolism, and in pregnancy, because of the thromboembolism only, they're having the problems of recurrent abortions, placental insufficiency, preeclampsia, and in IUGR and oligohydramnios, all these. So remember, thromboembolism is the central pathophysiology which is present in antiphospholipid antibody testing, and therefore the patient will be having a history of unexplained thromboembolic phenomenon. So remember, it's because of this pathophysiology we start with anticoagulants, that is heparin is started, or even low molecular weight aspirin is started off in once the pregnancy is diagnosed in such patients. Okay, so unexplained thromboembolism is a feature of antiphospholipid antibody syndrome. Now coming to the last option, that is severe preeclampsia in 38 weeks of gestation. Remember, in antiphospholipid antibody syndrome, because as we explained that the main pathophysiology being the thromboembolic phenomenon, there will be minor clotting within the placental bed or the placental blood vessels as well. So this will result in definitely higher incidence of preeclampsia in patients with antiphospholipid antibody syndrome. But remember, the preeclampsia is early onset preeclampsia. The patients normally in a normal pregnancy, if you consider the development of preeclampsia, they usually develop later in the pregnancy, right? So maybe like 34 plus weeks, the preeclampsia sets in. But in patients who are very high risk, for example, patients with antiphospholipid antibody syndrome or with any other autoimmune disorders like even SLE or a chronic hypertensive patient, the development of preeclampsia sets in earlier. Even before 34 weeks of pregnancy, the preeclampsia will set in such patients. Okay, so that is a very important feature. So here, what they've given the option is severe preeclampsia after, that is at 38 weeks of gestation. So that is not any way indicating that the patient is, having an antiphospholipid antibody syndrome, because in such patients, onset of preeclampsia would be much earlier, even before 34 weeks of gestation. So that's how you can differentiate between these points. And that, so if you go by the criteria, the option D would be not an indication. See, remember the question what they've asked is not an indication for antiphospholipid antibody syndrome, and the option D would be the answer for this question. So is it clear to all of you? The onset of severe preeclampsia in such patients will be earlier. It will be even before 34 weeks of gestation. So 38 weeks of gestation, having a severe preeclampsia cannot be taken as a criterion for or an indication for antiphospholipid antibody syndrome. Okay. Next one. A 38-year-old gravida 1 undergoes a routine sonogram to survey fetal anatomy at 21 weeks gestation. The cervical changes as shown below are found. She denies any complaints including contractions. On sterile speculum examination, she is noted to be dilated 1 to 2 cm with bulging membranes just past the level of the external os. She undergoes 24 hours of observation on labor and delivery without any change. What is the most likely diagnosis? Inevitable abortion, cervical insufficiency, arrested preterm labor, none of the above. Yes? Anybody?
Arrested preterm labor.
Sorry?
Option A.
Yes? Sorry? Yes, anybody answer? See, what they've given here is she denies any complaints, no contractions. So no pain abdomen, no contraction. It's a painless dilatation of the cervix. It's a typical seen in which condition? Whenever there is a painless dilatation of the cervix, typically seen in what kind of problem?
Cervical insufficiency.
There is dilatation of the cervix is definitely there. And even the membranes is what they are seeing. There is a funneling of the membranes and they're able to see at the external os. But she does not have any complaints, no contractions also, but the cervix is dilated. So it definitely indicates cervical insufficiency, is it not? So without any contractions, a normal cervix won't dilate, is it not? So in case of inevitable abortion, there has to be contractions and subsequent cervical dilatation. Whereas in arrested preterm also there has to be contractions, subsequent dilatation of the cervix. But in a condition like cervical insufficiency, the cervix is already opened up on its own. You need not have any contractions for the cervix to dilate when there is an inherent problem with the cervix itself. That is the cervical insufficiency. So remember, each and every point in this question is very important for you to understand what could be the option, the right option. So she denies any complaints is very important, and no contractions is very important. So in inevitable abortion and arrested preterm, you should have some amount of contractions, and with each contraction only the cervix dilates normally, is it not? Whereas here, the cervix is dilated, but the patient is having absolutely no complaints of pain or any contractions, and therefore it definitely indicates a cervical insufficiency. Is it clear to all of you?
Yes, ma'am.
Right. Next. Now, when counseling the patient in question 1823 regarding her management options, you offer her expectant management versus intervention. Which intervention is most appropriate? Circlage placement, daily vaginal progesterone, 17-hydroxyprogesterone acetate injections weekly, or expectant management with repeat cervical length in 1 week? What do you want to do in such a situation where the patient is already having cervical dilatation? The membranes are already propped down. So which would be the best option for her here? She's 21 weeks. Anybody? Yes? See, all these things you're going to do. Supplemental, the supportive therapy you're going to do with progesterones, hydroxyprogesterone, or even expectant management. But will they really help this patient who's already having the cervix dilated? What is most appropriate for this patient is what the question is. Which intervention is most appropriate is what the question is. So what would be the right answer for this one? It's A, is it not? Cervical placement or cerclage, cervical encerclage or the cerclage placement. So cerclage placement can be done in an emergency situation also in such a patient where she's come with cervical dilatation and she's 21 weeks. She's still not into any of the other complications like rupture of the membranes or completely into inevitable abortion. In such a situation also, we do emergency cerclage placement. Okay, so this option, that is cervical encerclage, can be a important intervention for this patient to save her pregnancy. Apart from, of course, these supportive therapies, the most important would be cerclage placement for this patient. Do you all agree and understood this situation? We do cerclage in the emergency situation as well in such cases. And of course, prophylactic encerclage is done in subsequent pregnancies. Okay. Now, next one. The patient in question 1823 elects to proceed with cerclage placement. What is the most appropriate statement regarding her probable outcome? A, there is 20% risk of delivery prior to term. There is a 33% risk of delivery prior to 35 weeks gestation. There is a 50% risk of delivery prior to 36 weeks gestation, or there is at least 50% risk of delivery prior to 28 weeks of gestation. This is again a theoretical question. If anybody has an answer, you can please tell me. Otherwise, we will just quickly go through the option. Now, this patient is almost cervix is dilated 1 to 2 centimeters. So she would definitely be at a very high risk of, failure of the procedure or going into a preterm labor, right? So what would be the risk for her? Any idea? You're all there with me, students? I hope there is no disconnection.
Option D.
Yes, ma'am.
Yeah, okay. Option D or B? D for dog or B for boy?
D. D for dog.
Okay. So yeah, that's the right answer actually. She'll be at very high risk of preterm delivery or failure of the procedure. So the answer here would be D, that is she'll be at 50% risk of having a preterm delivery within 28 weeks of gestation. Okay. Next one. In a woman without history of prior cesarean delivery, at what gestational age is removal of prophylactic transvaginal cerclage most reasonable? 34 weeks, 37 weeks, 39 weeks, or defer until the onset of the labor? Anybody? When do we clinically prefer to take out that cervical encerclage or stitch, cervical stitch? And remember, they have mentioned here there is no history of prior cesarean delivery. So there has to be a difference when we have to remove the stitch in a patient with previous cesarean section or in a patient with no previous cesarean section. So normally when there is no previous cesarean section, when do you want to remove the stitch of this patient? Yes, anybody with the answer?
No, ma'am.
See, It's 37 weeks. Okay, at 37 weeks, when you are sure that the baby has completely been matured, the lung maturity is complete, and once you remove the stitch, it's okay for her to go into labor and deliver. So 37 weeks is the ideal time we take out the stitch, 36 to 37 weeks. Okay, and that too in a patient with who has not had a prior cesarean delivery. But in a patient with a cesarean delivery, we remove it early by about 35 weeks or 36 weeks. There is no like fixed weeks, but we do remove it earlier than 37 weeks, so that if at all the patient has to go into preterm labor, there shouldn't be any chances of scar rupture again. So we remove it a much earlier, maybe about 1 or 2 weeks earlier in the patient with a previous cesarean delivery, right? And then we prophylactically we give her steroids because we are removing the stitch early, and anytime if she goes into labor or we have to take for an elective cesarean delivery, we immediately take up for delivery. So we don't wait until the patient goes into 37 weeks sometimes, because if she ends up in preterm labor, she'll be at a very high risk for a threatened scar. That's why we remove it a little bit early, maybe 1 or 2 weeks earlier. But in a patient with a previous normal delivery, or even this primary, if at all she is, then we wait until 37 weeks and then take out the stitch. Until otherwise, of course, she should not be in she should not be in the labor. Once she goes into labor, even if she's not attained 37 weeks, then we have to remove the stitch then and there, so that she doesn't end up in a cervical tear and all that. So even if it's a 28 weeks or 30 weeks or 32 weeks, if she goes into labor, and that too inevitable labor, then we have to remove the stitch at that time. But otherwise, if the patient is fine, no pains, no preterm labor, then we wait up till 37 weeks and remove the stitch. Okay. Fine. So the next question, which one of the following is an indication for transabdominal circulage? So most of the times we do transvaginal circulages, like what we have described earlier, the McDonald's, or the very complicated, if at all, it's Shirodkar's. Now, few people will end up doing or will have to go for a transabdominal. So, which is the following indication? Twin gestation, history of cervical insufficiency, history of failed transvaginal circulage, or prior preterm birth at 26 weeks gestation. So which candidate is most appropriate for a it's again an invasive procedure, that is transabdominal circulage. We don't do it for every patient. Only selected patients we go with transabdominal circulage. So anybody with this answer here?
Option C.
Yeah, option C is the right one. So whenever there has been a failed transvaginal circulage and the patient ended up with preterm labor, with in spite of having a transvaginal circulage, then such patients we go for transabdominal circulage. Other patients where we have to go for transabdominal circulage are patients with cervical amputation for fothergill surgery, or if the patient has been treated with cervical conization procedures for pre-invasive cancers and such procedures where the cervix has been amputated or damaged, then we have to go for a transabdominal circulages. So these are few indications for transabdominal circulage, but otherwise routinely we go as a prophylaxis with the simple procedures, that is transvaginal. Okay. When counseling a patient regarding prophylactic circulage placement, which of the following is a known risk? Bleeding, infection, membrane rupture, or all of the above? Yes, answer is all of the above. So all these risks are possible in any procedure of cervical circulage, is it not? So you need to inform the patient prior to the procedure that she is under the risk of all these, and anytime these could happen in spite of taking all the precautions. So the answer here is all of the above. Correct. Now, a 22-year-old primary gravida is scheduled to undergo suction dilatation and curettage for a missed abortion at 8 weeks. Prior to the procedure, the decision is made to place hygroscopic dilators. A single Dilapan S dilator is placed in the cervix, and a moist gauge is placed subsequently in the vaginal vault. How long will it take the dilator to reach its maximum diameter? 1 to 2 hours, 2 to 4 hours, 4 to 6 hours, or 6 to 12 hours? Anybody with this answer? See, in the dilatation and curettage, first procedure of dilatation of the cervix traditionally has been done by many methods. They have earlier used hygroscopic methods where they put up a hygroscopic material within the cervical canal and leave it there for over a period of time to dilate the cervix. Nowadays, what we use is the prostaglandins, like especially misoprostol, we use prior to the procedure at least 6 hours, and we keep it vaginally so that it will help in dilatation of the cervix. Subsequently, during the procedure, we use the Hegas dilators, to dilate it further. So Dilapan S is such material. It's a polymer hygroscopic material, and earlier days, few of the in the America they would use that, but nowadays we're not using. It's just a theoretical question. So it's a Dilapan S which is placed in the cervix, and anybody who knows the answer, it's again a theoretical answer. If anybody knows, fine. Otherwise, I'm going to give you the answer. How much time would it take to dilate dilate the cervix to its maximum with this Dilapan S? The other hygroscopic dilators are laminaria tents, and there are other certain synthetic polymers as well. Laminaria tent was the most commonly used earlier. Anybody with the answer? The answer is C. Okay, 4 to 6 hours. So it takes about 4 to 6 hours for the cervix to dilate with a Dilapan S. It is nothing but a synthetic polymer. It's a hygroscopic material used for dilatation of the cervix. Remember, it was used in previously. Nowadays, we don't use any of these hygroscopic dilators. We directly use the prostaglandins only. Okay. Next one. A 32-year-old multigravida is diagnosed with an embryonic demise at 7 weeks gestation. When counseling her regarding options other than expectant management, you explain that as compared to suction curettage, which has an efficacy of 96 to 100%, medical abortion is associated with what risk of failure? 2 to 17%, 4 to 9%, 5 to 26%, or 10 to 20%. Sorry. So medical abortion is where you follow the protocol of giving mifepristone and misoprostol for the patient, right? So 800 micrograms of misoprostol is given vaginally. So in spite of following the routine protocol, there will definitely be a chance of incomplete abortion or incomplete procedure or the failure of procedure. So what is the risk of failure in the medical abortion protocol? Anybody? Yes. Sorry, I didn't. It was not clear. Anybody with the answer? No, the answer is actually A. It is almost 2 to 17% is the risk of failure of the medical abortion, right? So just remember this one. Next one. The patient in question 1831, the previous patient, elects to undergo dilatation and curettage. Misoprostol is chosen for cervical ripening prior to the procedure. Which route of administration is thought to be least effective? Oral, vaginal, sublingual, or all are equivalent?
Sublingual.
Least effective. Remember, they've asked least effective.
Oral.
Vaginal. Yeah, answer is actually oral. Vaginal is definitely the most preferred one, as I told, and the mode of the onset of action is local and much stronger. So vaginal is what we prefer. Then subsequently, sublingual is the next option available, where with the sublingual administration, the onset of action is also faster, and the dosage of requirement is also lesser. And oral is the one which is least preferred because the onset of action is little higher. The time for the onset of action is duration is longer, and the dose also may be higher in requirement. So the answer for this question is oral, right? Next. This is again a theoretical question, and it's based on ACOG. But remember, which regimen is recommended by ACOG for prophylaxis of post-abortive infection? and CEF at the time of procedure, clindamycin, doxycycline, or doxycycline 1 hour prior, and 100, 200 doxycycline after the procedure. If anybody knows the answer, fine. If not, I'll give it to you. And this is not the protocol we usually follow. We can give any broad spectrum antibiotics, which is kind of recommended locally in your own, area or the country. So according to this, the answer here is D actually. That is doxycycline is what the ACAG recommends. Here in India, we do use other antibiotics like broad spectrum antibiotics also. We give orally prophylaxis of prevention of infection, especially in case of medical abortion. So I'll just skip that question. Next one. Which of the following is a relative contraindication to outpatient medical termination of pregnancy? IUD in situ, use of anticoagulation, severe renal, liver, or cardiovascular disease, or all of the above? Yes, students? It's a very easy one. Yes, anybody? All of the above, definitely. See, when there is an IUD in situ, do you go for, first of all, for a medical abortion? Whenever there is a pregnancy with the IUCD in situ,
No, ma'am.
no, is it not? So you definitely can't do a medical abortion whenever the pregnancy is there with an IUCD in situ. You have to opt for dilatation and curettage. Okay. And whenever the patient is on anticoagulation for any other reason also, you do not want to take the risk because she might end up in heavy bleeding at home. She may not be able to be monitored, is it not? So you don't want to give her a option of medical abortion and being managed at home without any supervision. So that's a contraindication. And of course, the last one, with any severe renal, liver, or cardiovascular disease also, you may not allow her to use the protocol unsupervised. So in some cases it is not indicated as well, especially in renal and liver diseases. It is not indicated. In case the termination is required, you would prefer to go for a surgical procedure depending on how much is the risk for her. And of course, in cardiovascular diseases also, you cannot leave her unsupervised in the outpatient basis. So all these are the contraindications for outpatient management of a MTP with medical abortion, right? Next one. A 22-year-old woman presents for elective termination of pregnancy at 7 weeks gestation. After counseling, she is prescribed mifepristone and misoprostol to complete outpatient medical abortion. She completes the dose of mifepristone in the office, but then calls back stating she has decided not to proceed with the termination of pregnancy. You inform her of the risks of mifepristone exposure in pregnancy, which include which of the following? 28% risk of preterm birth, 5% risk of fetal malformations, 10 to 46% risk of pregnancy loss, or none of the above. So we can, we face such clinical situations where some patients kind of come back to you saying that they would like to continue the pregnancy. They are in a dilemma. So how do you counsel such patients? Where she has taken, usually what we do in any protocol when we are administering the medical abortion protocol to anybody, we see that the mifepristone is taken under our supervision. We give it immediately to the patient after taking the consent, so that we are sure that she's kind of taken it properly, and then instruct her to use the misoprostol at home. So that is how is the protocol followed once the consent is taken from her. So even this lady has taken the mifepristone in the office, and then if she has to use 2 days later the misoprostol, she decides that she doesn't want to go ahead with the abortion. And then, of course, what would be the risks after taking 1 dose of mifepristone is what the question is. Anybody with the answer? Does it have effect on pregnancy or no? Mifepristone, does it have an effect on pregnancy or no?
Yes, ma'am, it affects pregnancy.
Yeah, so then what is
Options.
the most important risk that the patient is worried about, or you have to counsel her?
Risk of pregnancy loss.
Yeah, risk of pregnancy loss is there, but if at all the pregnancy continues, what is more important or concern to her is 5% risk of fetal malformations. Okay,
Malformation.
So this is the important point what you have to remember and counsel, that if she wants to continue the pregnancy, if at all the pregnancy ends up continuing
Yes.
in spite of taking mifepristone, then she is under the risk of having 5% risk of fetal malformations, right? So this is the right answer for this question. Okay. Next one. A 24-year-old woman with missed abortion at 6 weeks gestation elects for outpatient medical treatment. You prescribe 800 microgram of misoprostol to be taken up to 3 times 3 hours apart. What of the following are side effects of misoprostol? Diarrhea, vomiting, fever and chills, and all of the above. Which is the most common side effect of misoprostol? Anybody?
Diarrhea.
No, it's not diarrhea, not even vomiting. The actual answer is fever and chills. Okay, so it typically causes fever with chills, and the patient ends up having a mild fever for some time. And usually we give paracetamol for such patients. And once we give paracetamol, it usually settles down. So hyperpyrexia is one of the important complications of high dose misoprostol. Remember, especially when we're giving 600 dose of 600 micrograms of misoprostol in postpartum hemorrhage cases, or 800 in medical abortion, some patients are sensitive and they end up in hyperpyrexia with fever and chills as an important and a very common side effect in case of such administration, right? So remember, it's a fever and chills. Okay. Next, what is the risk of uterine rupture with medical termination of a second trimester pregnancy in the setting up of one prior section delivery? Anybody with this answer? It's quite close, actually. The options what they've given are quite close. So whoever has read the theory part very carefully will be able to answer this. If not, if you're confused, just leave such questions. You know, that's how you should be able to kind of avoid any negative marking. Anybody with this answer? Okay, I'll give it to you. The answer is B, that is 0.4%. So the risk of uterine rupture in any medical termination in second trimester abortions with a prior one cesarean section. Okay, so the risk again, it's going to increase with the number of cesarean sections. Remember, with one prior cesarean section in a medical termination for second trimester, the risk is 0.4%. Okay. Now, coming to this question, it's probably the last one. As compared to pregnancies that are continued, the maternal mortality rate with first trimester termination of pregnancy is lower. What is the approximate mortality rate associated with induced abortion? 1 per 1 lakh, 2 per 1 lakh, 5 per 1 lakh, or 7 per 1 lakh? This is a general incidence, excluding any septic abortion cases. It's just the general incidence in induced abortions. Anybody with this answer? Yes. Yes, students.
5 per 1 lakh.
It's not 5 per 1 lakh. The answer is the answer is 1 per 1 lakh actually. Okay, it's A. So the maternal mortality with first trimester induced abortions, it is 1 per 1 lakh. That's the answer. So with this, we come to the end of the question answers based on abortion topic. We have covered the most of the theory, relevant theory, and I hope you have understood all the concepts in abortion, especially the concept of what we call the when do you call a normal pregnancy and when it is abnormal based on the ultrasound findings. And you should be able to identify different clinical types of abortions, as we mentioned earlier. What is a missed abortion, what is a inevitable abortion, what is threatened abortion. So you should be able to identify what are the different clinical scenarios, clinical findings in each of these abortions, and what are the causes for abortions is what is important again. right? So the causes will be different in the first trimester, the causes will be different in the second trimester, and how do you manage each possible cause is again what is more important. So that all we have covered, and if anybody has any doubt in this topic, or if you want more information, or if there are any other questions which I have not covered in this topic, and if you do have these questions with you and if you're unable to find the answers, so please get back to me. We can all discuss in the forum of the WhatsApp group as well, not only in this classroom. So I hope you had a good session and a complete thorough discussion on abortion. That completes that topic, and in the next week I'll be taking up a different topic. So anybody has any queries regarding this topic, that is abortion? I hope it went well and you all have got enough information on that. Yes, students?
No doubts, ma'am. Ma'am, could you please send the abortion part 3 link, recorded video link, ma'am?
Part 3 video link, is it? Okay,
Oh,
fine. I'll just find out. Dr. Bilgi has done it for us, so I'll find out from him and then share it in the WhatsApp group. I'll do that.
okay, ma'am. Thank you, ma'am.
Okay, right. Thank you. So, any particular topic you would want for the next class for me to cover up?
Don't know, ma'am. I'm in third year only.
All right. So
Don't
as
know.
it is, we are going up with the obstetric topics, and I have covered the abnormal topics like in accordance with the hemorrhage in pregnancy. We have covered up the APH, PPH, and now the abortion. So yeah, subsequent classes I'll try to take up another topic and come up with the theory as well as the question answers. So thank you all students again to be here with me. And as I told, if there is anything you would want to suggest or ask, you can always get in touch with me. So I wish you all have a good night, and yeah, thank you all again.
Thank you, ma'am.
Thank you. Bye.